I wanted to just say what an honor it is to be included in today's program. And my comments this morning will complement what Dr. Lambert has started introducing to you. And I also want to make some additional comments on a little bit more of a broader scale regarding really what's happening here today. And I'm going to come back to that comment in just a few minutes. The first thing I want to do, I had a massive identity crisis when I left the NIH and I went to the University of Maryland in Baltimore. I arrived in my office, small office, but it was nice, and I got a call from a number of friends, and one of them, a well-known surgeon on the West Coast, said, "Well, how are you enjoying Johns Hopkins?" And I said, "Well, actually, I'm not at Johns Hopkins." And he said, "Well, where are you?" And I said, "Well, I'm at the University of Maryland Medical Center and School of Medicine." And there was a pause on the phone, and he said, "I didn't even know they had a medical center." So I am on a personal campaign to basically introduce the medical center to as many people as I possibly can, and this is actually it in West Baltimore. And I will say that it's a very interesting situation in that people say, "Well, what about Johns Hopkins? And what about the competition?" I will tell you that it was immediately clear to me the moment that I arrived in Baltimore that there is an era of glasnost now in Baltimore. There's openness, there's dialogue, and there's an appreciation that we're not each other's enemies. The diseases are the enemies, and we need to work together to try and come up with better ways for diagnosis and treatment. And we do work very collaboratively together. But this is the University of Maryland School of Medicine and all the associated. I'm going to see if I can find the pointer here. Oops, that's not it. Now I'm going to need help. That's it. And I'm going to go back to this and go to the slideshow. Did it. This is actually the 5th oldest medical school in the country. It's the oldest public medical school. And the original building is tucked right in here, built in 1807. And this is now the hospital complex with all the research buildings and the associated professional schools around it. Now, just to build a little bit on what Dr. Lambert said for a few minutes, I want to introduce some very important concepts that relate to the treatment of appendiceal neoplasms. It's not just one disease. It's a family of diseases, as you've heard. And the behavior of these diseases spans a broad spectrum. They share many common features, but they have certain distinctions from each other as well. And the different types of growths that we encounter that arise from the appendix are really defined by their distinct appearance under the microscope, which then largely relates to their subsequent biological behavior. A rare condition. I don't think it's as rare as we have historically thought it to be, and that may be due to a number of different factors, including the ability to really diagnose it more accurately and report it more consistently in recent years than we have in the past. As you have heard, there are basically two large distinct classes of appendix tumors, the more benign DPAM and the more cancerous PMCA or peritoneal mucinous carcinoma. But it really is a spectrum. And very commonly, as we meet in our multidisciplinary groups to review the pathology, we struggle to look at a specimen under a microscope, and we see a range of features, some which belong to one class, some that belong to another, and we try to define to our best ability what's the dominant feature of this type of tumor, this particular tumor, that will allow us to understand what we predict it to be and its biological behavior and what would be its most appropriate treatment. But it's not always very straightforward. The term PMP has, I think by convention, been used to describe the slower growing type of condition, the DPAM condition, but from a medical perspective, when you look at it from its strict terminology perspective, the term pseudomyxoma peritonei can refer, in fact, to any kind of a condition in which mucinous material is the predominant manifestation of a growth that has arisen in the abdomen. And it can arise from any organ. It could be the stomach, it could be from the colon, it could be from the ovary, but by convention and historically it has been most commonly ascribed to a condition associated with the appendix. One of the things that we appreciate about this condition, which is remarkably consistent, is that it tends to spread, when it does, almost exclusively into the abdominal cavity. And it's very rare that an appendix neoplasm of any type will spread through the bloodstream and begin to manifest itself with sites of disease outside of the abdominal cavity. So this is a very predictable kind of a biological behavior that has really been the foundation for our development of approaches to control this condition in the abdominal cavity. You know, I do have some clinical slides, and I thought hard about whether or not to show these, but I thought because of this particular audience being so motivated to learn and understand this condition that I would do so. And I should have warned you that I do have a couple of these types of slides, but I thought you all deserve to see firsthand what this condition actually looks like. This is an informative slide which shows basically a piece of intestine. And this yellow membrane here is the glistening mesentery that normally would be smooth and shiny. But as you can see, it has many small excrescences on it, and these are individual tumors that started in the appendix. And when the appendix burst, the tumors were able to kind of seed the entire abdominal cavity and implant on the tissues where they can continue to grow and form this mucinous material very frequently. Once you see a spot, or just 2 or 3 in the abdomen, to me, it's an indication that the entire abdominal cavity is at risk of harboring invisible or other very small, hard to detect sites of disease. And so I believe that once you see a single spot or a couple of spots, you've got to consider the entire abdominal cavity as a site that needs to be addressed and treated. Otherwise, invariably, the tumor will show up in other areas over time. Now, let me just go back in time a little bit. 1980, not that long ago, 30 years. I think the medical oncology community, the medical community at large, had really a very nihilistic attitude, frankly, about our ability to treat in a meaningful way any abdominal growth that had spread into the peritoneal cavity. Generally, people were consigned to receiving only palliative or limited interventions to help them with their symptoms, and there was never really any systematic approach to tackling these problems in a coordinated way. Over the course of the last 30, 35 years, I think we've made great strides to the point now where we do have very sophisticated and I think very effective programs in place for individuals with colon cancer, appendix cancer, mesothelioma, and ovarian cancer, all of which are a family of tumors and cancers that will spread exclusively into the abdominal cavity. And each one is treated with some distinctions from the other. As Dr. Lambert had mentioned, the disease, appendiceal neoplasms, appendiceal tumors of any kind, stay confined to the abdominal cavity, and as a consequence, the problems that will occur in any individual are almost exclusively related to the growth of the tumor in the abdominal cavity. And so that is why we have spent so much effort in developing these complementary strategies to try and control the tumor in that one particular area. This is a CT scan showing a very advanced condition. This is what happens over the course of many, many, many years when this mucinous material can gain a foothold in the abdomen and cannot be adequately controlled. This is a CT scan with the patient's head behind us, the feet out towards us, and all of this is mucinous material that has built up and now has gained the ability to grow into areas where it would normally not be encountered, in the abdominal wall and beyond. It's one of the later manifestations of this condition. These 2 CT scans, to me, and I think to most radiologists, would look very, very similar to one another. This is a CT scan showing some thickening in the omental tissue, which is a fatty apron that sits in the abdomen. The rest of the scan looks largely normal. This is a similar scan which shows a similar finding of a thickening of the omentum and otherwise no abnormal findings. And yet these 2 individuals suffered very different fates. One had a very rapidly progressive appendiceal cancer, and the other had the more slowly growing disseminated peritoneal adenomucinosis. Yet it was impossible for us, based upon our preoperative imaging studies, to really appreciate the very different biological behaviors of these tumors. And it highlights a very significant limitation that we have in our management of this condition today, which is that we really can't tell the biological behavior of these tumors and who will be the best ones to approach with a surgical option versus a chemotherapy option based upon radiographic appearance. We have significant limitations in this regard. CT scans, as sensitive as they are, will oftentimes underrepresent the extent of the problem in the abdomen. This is a scan that, at first blush, doesn't look particularly ominous to me. If you look at it, it's all normal, except for a very subtle single finding of some mucinous material behind the spleen sitting up in this area. And yet this is an individual who, at the time of operation, was found to have widespread, extensive peritoneal dissemination from an appendiceal cancer. So it's very common that we will get to the point of actually starting an operative procedure in an attempt to provide a therapeutic cytoreduction or a systematic removal of the tumors, and find, unfortunately, that the disease is far more advanced and very different than what the preoperative scans would have indicated. This is a typical picture of an individual with mucinous material in the abdomen, and as it progresses, you can see that it will encroach upon the normal organs. This is the liver here, and the mucinous material is pushing in along the sides of the liver. It's crowding the intestines here, it's filling the pelvis, but it's very common for slowly progressive conditions to really cause minimal symptoms. This is an individual who felt nothing other than just bloating, but the digestive system and otherwise that individual was doing fine. So even though the x-rays can look very daunting in some circumstances, the growth of the condition is favorable for us to go in and remove it and to, what I would say, meaningfully reset the clock to provide somebody with a long-term clinical benefit from having this mucinous material become problematic. Now, probably in the early 1990s, late 1980s, there was, let me go back half a step. In the mid-80s, there was a description of a strategy that was first championed by the Japanese to systematically go into the abdominal cavity and remove the spread of tumors that had occurred in the abdominal cavity, primarily from gastric cancer. This was a major problem in Japan. They systematically tested this concept of cytoreduction surgery with the intraperitoneal chemotherapy. And it was then thought that it might be useful to try against other types of conditions. And the first report of using cytoreduction and intraperitoneal chemotherapy in the United States was actually just in 1980, and it was the only one that was done for almost 10 years. And it was a very motivated individual who actually had driven around the country looking for some help with his pseudomyxoma peritonei, and at the University of Louisville they agreed to perform the cytoreduction and perfusion, and that was a case report that was published from that institution many years ago. But it still took us another decade before we started to systematically employ this type of a strategy. And all through the 80s, there were a number of institutional reports showing that it could be done and that there were some people who derived significant benefit from it. Now, the reason for this approach, or the justification for it, is that the tumors will very frequently be amenable to physical or surgical removal. And that's because they sit on the lining of the abdominal contents. The appendiceal neoplasms tend to remain confined there. So we know that this is a reasonable approach to take because of its very predictable biological behavior. The use of chemotherapy into the abdomen, to me, is something that has become very commonplace. We're doing it a lot more commonly, but I've made the criticism that I don't think we're doing it particularly thoughtfully. We don't have the data that we need to show whether or not it actually does what we think it may do. The intellectual reasoning behind it is quite compelling, that you're putting a very high dose of cytotoxic chemotherapy directly on the tissues in the abdominal cavity with the hope of obliterating cancerous cells. But whether or not that can be accomplished in practice is really something that we don't know. Now, why HIPEC? Why not just put in a catheter and give chemotherapy into the abdomen after surgery? And I think that the HIPEC technique is probably, in my opinion, the most effective strategy of applying high-dose chemotherapy to all of the complex little nooks and crannies and recesses of the abdominal cavity. It's done at the time of surgery when there is no scar tissue. It's done when there is minimal disease in the abdomen. You can use hyperthermia, which has been known for decades to be a very effective method of killing cancerous cells. Hyperthermia has direct cytotoxic actions on cancerous cells. The cell membrane of a cancer, the cancer cell membrane is very vulnerable to heat and can lyse open very, very easily, whereas normal cells are much more resilient. Hyperthermia also has the ability to help deliver chemotherapy selectively into the tumor cells themselves. So it has direct and indirect effects. And we don't use hyperthermia in clinical practice commonly because we can't heat the entire body up to the levels that we would normally need to see those effects, but we can heat up the abdominal cavity. So there's a lot of intellectual reasoning behind the use of HIPEC for the management of peritoneal dissemination from appendiceal cancer. The technique has a lot of mystique to it. It's a very straightforward one. You basically open the abdomen, you systematically go through each of the different quadrants of the abdomen to take out the tumors that you can see. You then place large catheters into the abdomen, you close the skin, you connect these catheters to a very standardized machine. We have one over there on display that basically recirculates the fluid through the abdominal cavity at a high rate so that you can uniformly heat the tissues. And once the 90-minute interval of treatment is over, you stop and the procedure is over. I do have a couple of clinical slides, or operative slides that I want to show you that highlight the technique here. This is just a schema showing what it looks like, an individual lying here with the catheters connected to the abdomen, and there's an older version of the perfusion circuit. This is peritoneal dissemination in the right upper part of the abdominal cavity. And basically, this membrane here is like a piece of saran wrap that lines the entire abdominal cavity called the peritoneum. All of this is a carpet of tumor from an appendiceal cancer, and there's one tumor sitting right here that you can see that's bigger than the others. And basically, what you do with a peritoneectomy is you strip this lining out, and you can see underneath the lining is the normal diaphragm muscle. And in fact, if you can continue, you can get all of that tumor out of that area of the body. That's one section out of probably 10 or 12 that you can go around and perform similar types of procedures to successfully remove these tumors. Now, there's lots of criticisms that I could level against the community of us that are involved in this treatment. Most of the reports that have been published in the literature over the last 20 years are really single-center, retrospective reviews of what our experience has been like. We've really done very little from a prospective perspective, that is, trying to answer a question by doing a carefully conducted clinical trial. A lot of the outcomes that we have seen published vary, and they vary because we don't have uniformity in how the patients are selected for operation, the extent of the surgery that's performed, the parameters that we use for the treatment using HIPEC. These are all variable depending on what institution you look at. And so it's very difficult to really understand how much of the results that we see are due to our intervention versus our ability to select the person who's going to have an inherently good outcome anyway. And we don't know what the contribution of the HIPEC is on top of the surgery and other treatments that an individual may get. Under extreme circumstances, you can get very significant abdominal distension. And under these circumstances, clearly, if the tumors are in positions where we feel that a bulk of it can be removed, I think that it is certainly appropriate to do so in terms of helping somebody with respect to the symptoms that can occur with this kind of condition. We use a system which is very cumbersome to try and assign a score to how much tumor we see in the abdomen. And I think that's very important for us in terms of understanding how to interpret results. So we go through the abdomen and we look at the amount of disease that we see in all the different sections of the abdomen. We add up and we get a final score. That's called a peritoneal cancer index. There are a number of different systems that have been proposed in the literature. And again, part of our problem as physicians who treat this condition is that we haven't had uniformity in how we've scored the extent of the disease in the abdomen. At the end of an operation, there's another very important scoring process that has to take place, and that's to quantitate how much tumor is visibly left in the abdomen. And there's a score of between 0 and 4 that have generally been proposed. Keep in mind that generally a score of 0 or 1 are considered to be the good ones, and that if you have a higher score like 2, 3, or 4, the likelihood that the surgical procedure is going to translate into a very long or durable benefit is diminished. This is an actuarial survival curve that shows in a large group of heterogeneous patients what the outcome with appendiceal neoplasms is likely to be. You can see here that many people do very well for a long period of time. And what you need to do, though, is you need to break down that large group into the subsets of people that have the high-grade cancers versus the lower-grade DPAM to understand that not everyone does the same. The cancerous condition tends to have a much more pesky personality to it, as opposed to the DPAM, where people can live for many, many years with really no significant problems with the condition. At the University of Maryland, we are trying to integrate a plan of care that includes chemotherapy given before and after surgery in many patients. The results basically are here, showing that in patients with very, very high-grade cancers, that the outcome looks somewhat promising based on a preliminary analysis, but we need to do more studies to really understand whether or not chemotherapy should be routinely used in this condition. There are complications, clearly, associated with this condition. You know, one of the things about surgeons that is unique in all the different specialties in medicine is that we have conferences every week in our hospitals where we talk about nothing other than complications. And many of the reports that initially were published using this cytoreduction and HIPEC surgery were basically focused on the complications associated with it. Clearly, we've learned a lot over the last 15 years on who should and should not be candidates for surgery. What kind of surgery should be done? How do we care for these individuals after surgery? And so I think the complications have now decreased to a point where I feel that they are, when you look at a risk-benefit analysis for an individual, that very commonly it's far better to take a few risks to try and get a handle on this condition surgically than not. But I do tell everyone that, you know, you have to be prepared that there can be some expected things that will happen after surgery. Generally, about 40% of the time, something is going to happen that's not expected. It may take a few extra days in the hospital to help get over that. If you look at what are the reasons why people have complications, one of the things that I find interesting is that if you have to remove a lot of intestines and make new connections, that stands out as a very, very important factor that indicates that that individual is at kind of high risk of having infectious complications after surgery. And if there's a lot of tumor in the abdomen, then that obviously puts people at a higher risk of having complications. On the other hand, what about quality of life? Most people take, as Dr. Lambert mentioned, between 6 to 12 to 16 weeks to recover from the procedure. I prepare them that the process is a lot longer than what they might be prepared to admit at the outset. But beyond that, what's in store for the first year or two of life? Well, we did a study when I was at the NIH looking at quality of life after cytoreduction HIPEC, and what we found was, I thought, quite striking. These are quality of life scores. For the average United States population, 50 is the median number. So a number below 50 means that your quality of life is less than average, and a number at 50 or above means that your quality of life is average or better than average. And if you look at the physical and mental component summary scores of individuals before their cytoreduction and then at various periods afterwards, you can see predictably that at 6 weeks after surgery, they're not generally feeling as well as they did before surgery. But starting at 3 months, 6 months, 9 months, and not shown here, but going beyond a year, the quality of life stays very good for most individuals. And that's particularly true for the mental component summary score. And it's interesting that even at 6 weeks, when you're not feeling good physically, you're feeling good mentally because you've done something to attack this disease. And I think that that's reflected in the quality of life surveys. And you can see that that continues to be sustained through the first year. That was as long as we actually measured the quality of life outcomes. And I contrast that to the alternative approach, which would be to perhaps give somebody continued chemotherapy, oftentimes for many months on end, which can clearly have detrimental effects, toxicities in and of themselves. So even though it's an intensive treatment to get through, I think in the appropriate individual, it can translate into a very meaningful and durable improvement in quality of life. Just for the next few minutes, I wanted to shift on what I think is a very important topic related to appendiceal cancer, and it relates to what's happening in this room here today. You know, we face a lot of challenges when it comes to improving our treatment and improving the outcome when we try to attack this disease. And I look at the major challenges relating to increasing awareness, increasing research, and increasing teamwork. Now, with respect to awareness, I cannot underestimate to all of you how important your presence in this room is today. This increases awareness in ways that I don't think many of you can fully appreciate. Advocacy for cancer research is at the roots of the very beginnings of the treatment and the conquest of cancer in this country, going back over 100 years. And I'm going to tell you a story which I think reflects what's happening here today, which really, in my view, was the beginnings of the incredible cancer infrastructure, research infrastructure that we have in this country today. This is a picture of a 17-year-old girl and her friend who's an 18-year-old boy. This is Bessie Daschle. This picture was taken in 1889 in Manhattan. She was a very outgoing, sociable young woman. Her friend was introduced to her by Bessie's older brother. They were classmates at a private school in Manhattan together. And based upon the correspondence that existed between them, there was speculation from some historians that if fate had not played out differently, that Bessie and her friend would have probably married and had a family. Turns out, in 1889, some months after that picture was taken, Bessie Daschle took a trip across country with her family. And on the train, she injured her hand, and she developed some persistent, painful swelling on the back of her hand. And in September of that year, she sought help from a young surgeon in New York City who basically excised it, thought it was infection, but the report came back as cancer. He tried multiple times to control this condition by repeating surgeries, and ultimately in November of 1889, she underwent the draconian step, if you can imagine, this beautiful 18-year-old woman, of having her arm amputated above the elbow. But the story gets even worse. She never left the hospital. The cancer consumed her body, and over the next 3 months, she suffered from multiple organ failure and ultimately died of this condition in January of 1891. Her friend was John D. Rockefeller Jr. And at that time, he was a freshman in college, and he was so affected by her death that he withdrew from college, and he spent over a year at the family compound before he went back into his college studies again. And as all of you know, he spent his entire career, a vast portion of his personal wealth, and a lot of his energies with his father on the conquest of cancer. At the time that this problem occurred, cancer treatment in the United States was nothing like we see today. There was no National Cancer Institute. There was no National Institutes of Health. There were no formal cancer centers in this country. People with cancer were basically consigned to asylums on the outskirts of cities where they were treated palliatively for their pain and the consequences of their cancer. There was no chemotherapy. There was no radiation. Surgery was in its infancy with respect to its ability to treat cancer as a discipline. But he proposed that with funding and awareness, that cancer was a disease that could be studied and conquered. And that's why you're all here today, because you believe the same thing. He was the major supporter of cancer research in this country for 25 years before the National Cancer Institute was even founded. It was done all through personal appeal, individuals supporting cancer research. So it's in our blood. This is the way we conquer cancer, is getting together and raising awareness and conquering it by studying it. And I think that that's what's reflected here today. Cancer is the #1 cause of death in America now, in all Americans under the age of 85. This is a problem because for us who study appendiceal cancer, we have a massive public health problem, and appendiceal cancer is just a tiny fraction of that. At the NIH, we have over a $6 billion budget every year, which is used to deploy a very sophisticated infrastructure and program of cancer research, improving treatments, improving methods of diagnosis and prevention. And if you look at the top cancer killers, appendiceal cancer is not on there. Well, how do we compete for NIH funding when we have this daunting reality that there are many more serious public health problems in front of us? There's no question it's a rare disease. There's no question that NIH funding for cancer is limited. And I can tell you nowadays the statistics are very daunting. Less than 10% of every investigator-initiated research proposal submitted to the government is funded. And yet half of these proposals are scored as having potentially high impact. And I'm not certain, frankly, that we're smart enough to know where the next big breakthrough in cancer is going to come. And I'm not certain that we have the ability to understand that even studying a rare disease like appendiceal cancer could have broad impact on our understanding of much more common cancers. And so that's why organizations such as the PMP Research Foundation supporting this program today, and all of you here, I think are extremely important because we're going to have to do this on our own. I don't think we're going to be able to rely on the government to help us support this to the degree that we would all like. And I'm going to close by just revisiting a little bit of information that was proposed today by Dr. McAvoy, because I was profoundly struck when I read his papers, and I've read every single one of them, in which he's showing that a bacteria found in this cancer may have an important role in its progression and development. You know, there are probably experts in the field that would discount his work and say it's irrelevant. It'll amount to nothing. And I want to tell you that that's been something that has happened before. But we have to appreciate that the greatest discoveries in science are sometimes unexpected. And I'm going to give you one closing example. Through most of the 20th century, peptic ulcer disease was thought to be a disease that was very well understood by the medical community. It was simply acid overproduction in the lining of the stomach that caused ulcers. And for years, people with peptic ulcers were treated with antacids, with antacid diets, and it was a chronic condition that they were faced with for their entire lives. Robin Warren and Barry Marshall, pathologists and a gastroenterologist working at the University of Virginia, found that when they did biopsies of the ulcers from patients who are undergoing endoscopies, that they saw these little tiny inclusions in the ulcer material, and they hypothesized that these were bacteria, and that it was the bacterial infection that in the lining of the stomach that was resulting in the ulcers, not just antacids. And so at the time, their work was considered to be of marginal or questionable significance. Their hypothesis went contrary to the prevailing theories of the day. The treatment was known to be simply to block acid production or overproduction in the stomach. And my question would be, today, if they were proposing to do research on this, would they have been in that top 10%? I don't know. But it turns out that in 2005, they won the Nobel Prize for their discovery that Helicobacter pylori, the same exact bacteria that Dr. McAvoy is finding in PMP, was the fundamental cause of ulcer disease. It fundamentally changed how we treat ulcer disease. Now, not with antibiotics, not with antacids, but with antibiotics. So we need more innovative ideas, just like his, to try and drive our progress in this area forward. So where do we go? I think we need improved awareness, advocacy groups. We need more research funding through the PMP Research Foundation. We need more organization through Symposia like Dr. Lambert has put on today. And we need to have more quality internet resources for individuals to understand what their options are and how to get to centers that can give them the full spectrum of treatment options. And I think we need research and teamwork, particularly coordinated efforts to look prospectively at studying some of these new ideas that may end up being major breakthroughs in this condition. I thank you all very much for your attention.